I'm John Moore. 7 years ago, well, 6 years ago, I quit practicing medicine. I quit out of embarrassment because of the kind of relationship that I could have with my patients. I took the time with them in the office to talk to them, to make shared decisions with them, to really get them engaged in their care. But once they left, we were disconnected. So I resolved to dedicate my career to really building new paradigms of care to help patients get involved. And over the past 6 years, I did research with my colleagues at the MIT Media Lab to explore new types of technology approaches, new types of relationship approaches in order to get those patients involved. And the culmination of that work was the concept of patient as apprentice. So instead of thinking about just making data flow so that doctors have the blood pressures for patients and that they can communicate, instead it's about building self-efficacy. It's about working as a team out there in the real world where people live so that they can learn through the process and become the masters of their disease, to put it under their thumbs and to move on. And to give you a sense of what apprenticeship can do in healthcare, I want to talk a little bit about hypertension as an example. Our care delivery crisis is highlighted by the fact that currently 30% of hypertension patients reach goal blood pressure in the course of a year under today's standard of care. It costs about $250 just for those office visits and the care delivery. In a randomized controlled trial of our apprenticeship paradigm with a new technology platform for engaging patients at the MGH, we were able to get 100% of patients to reach goal blood pressure in only 3 months. So with a quarter of the time and 3 times as many patients. And we were able to do so at $70. At the end of this, patient said, no one ever asked me to really take an active role in my care. They never gave me the chance to be in charge. And I really liked having someone to support me through that process. And what we believe is this is what clinicians want to provide. The tools just aren't there yet. So now at Twine, we're building this out for everyone to use. It's about building self-efficacy. It's about maximizing collaboration through these tools. And it's about helping patients become the masters so that they can coach others. That's part of apprenticeship. What this looks like, Clarissa is a nurse coach on the left-hand side. She can look at her population of patients and see, well, who doesn't have a plan for their hypertension? Peggy happens to be one of those. She digs in, she meets with Peggy, and she talks about, where's your blood pressure now? Can we set a goal together? These are the risks. What's your motivation behind this? How can we get there? Look at real concrete numbers. If you lose 10 pounds, how much can we get down your blood pressure? And let's set a plan together that we can work with once you leave the office. That synchronizes to Peggy's cell phone. Right there in the office, she learns how to take her own blood pressure, to enter it into Twine, and it flows in real time back to Clarissa's dashboard. Now, flash forward a week from now, and Clarissa's in her office, and she looks at her population of patients, and she says, well, who's having trouble? Who needs my help? In Twine, she can just go and see who's not adherent to their plan, and Peggy pops up to the front. She can dig in and see, well, Peggy was doing great. She was taking her blood pressure, she was taking her medication, but then it stopped. Normally, she would have missed that, but now she reaches out to Peggy, fires a message. Peggy gets it right in her app here, and Peggy says, well, I had a side effect. Turns out that 50% of patients stop taking their hypertension medications in the first month. Pretty consistent for diabetes, pretty consistent across chronic diseases. Twine helps stop those gaps in care and helps patients and clinicians work together as a team to build this self-efficacy to reach their goals. So the value proposition here is in value-based care. It's where we need the experience, the outcomes, and the cost reduction. And with a drop from $250 to $70 in caring for patients, that's $180 in profit per patient per year. That's over $100,000 in profit for a clinician. The reason I highlight this is if we want to provide great care, we also need to make it economical. And where we're headed now, in pilots with a lot of prestigious institutions around the country, is to really optimize this, to do it across diabetes, COPD, asthma, We're adding one-click secure virtual visits with patients where you can reach out to them in their homes. And we're integrating smart tracking through devices through Apple Health Kit and Google Fit. And I just want to close with saying that at Twine, we believe that technology is not the solution, it's people. And what we provide is a tool to allow them to really create that relationship together, get the technology out of the way, and help us set goals and achieve them as a team.
So one of the very first bar graphs you showed, I really liked that graph, and your 20, I think it was even less than, what's your figure on the red bar? 20%,
yeah, so it's 30% of patients.
And then your blue bar was 100%. So can you tell us about the people in that 100% bar, and in what ways are they, and also aren't they like the people in the whole rest of the country in the red bar?
So in that particular randomized controlled trial, it was 40 to 75-year-old patients, ranging, they were workers at the Massachusetts General Hospital, ranging from janitors to medical doctors. What we find is that those characteristics are absolutely not predictive of success. It is not perceived health literacy. It is not socioeconomic status. It is the value proposition to that patient. So how complicated is their life at home? How much do they want to avoid coming into the office? How motivated are they? And we found that consistently in research across all kinds of socioeconomic groups. So the short answer is quite representative of the real world. And in fact, the focus is not on those factors, but on the motivation to begin with.
Thank you, great presentation. Some of our patients who are the most challenging to treat have got visual impairments, physical impairments. Their digital literacy is very limited. What is your kind of game plan for those that are really difficult to treat patients, or patients who have got these kind of physical or sensory limitations?
Yeah, so I think those are two different questions. What we find is that folks who are seemingly difficult in terms of technology competency, not an issue. We've had a 75-year-old woman with a hemoglobin A1C of 10, never touched a smartphone or a tablet before, in 2 months down to a 7. And she had no interest in using the technology to begin with. She had an interest in that relationship with a clinician. A husband at home with dementia who she didn't want to leave at home by herself. So if the value proposition is there, people will learn it quite quickly. The second question of actual sensory deficits, a little more difficult, but fortunately most technology tools these days have accessibility options. In many of our elderly patients, we rely on tablets instead of smartphones, and we design the interfaces to really be designed to be usable for those types of patients.
One more question. I really liked your example. You walked us through how the coach engages with the patient. It seemed like it required quite a bit of time from the coach's perspective. Which healthcare provider in the community health center is expected to operate this kind of this platform?
Sure.
Is it your typical primary care doctor, nurse practitioner, PA? How do you envision the program rolling out?
Yeah, across our sites, it's typically anywhere ranging from an RN to an LPN to a care navigator, care coordinator, health coach. So some are clinically credentialed, some are not. We're measuring the differences there, because with a health coach, there's a little bit more of a care coordination cost because the physician needs to be looped in at key points. It turns out to get the average patient to their hypertension goal, there's 0 to 1 changes in their plan throughout the course. It's predominantly support-based as opposed to plan adjustment. So there's not a lot of coordination costs there. But an RN prescribing under protocol can make those adjustments on the fly without without a physician approval, so therefore there's less coordination costs. So we're measuring all that to figure out what is the ideal scenario. But typically, it's someone who's working tightly on the team with the physician, but not the physician himself or herself.